We now move to Secretary, Indian Medical Association, Dr. Shubnam Singh, Chief Executive, Max Health Education Research, Mr. Krishan Girdhar, MD, Presto, Mr. Terig Hughes, MD, Read Elsevier, India, Mr. Rohit Kumar, Founder and CEO, Chapter Apps Incorporation, Dr. Sandeep Bhalla, Program Director, Training, Public Health Foundation of India, Dr. S.D.Gupta, President, APAMI.
I think there are a lot of people who are outside and having a cup of tea. Can we announce? Is it possible to announce to let people bring their cup of tea inside? That'll be great so that we can start on time. Please.
Sure, sir.
Share this very, very vital event and moderate this session with the many stalwarts sitting on the dais. They come with diverse backgrounds and absolutely unbelievable accomplishments. The subject of this afternoon is of a very high priority in the National Policy Initiative to facilitate availability of clinical information at the point of care to achieve the highest attainable standards of technical efficiency, clinical effectiveness, and quality in the delivery of care. We have yet another stalwart who's walking in. Dr. Shubnam Singh, please kindly occupy a chair where you would like to. And very welcome. Now, I said that we have a galaxy of stalwarts from the healthcare industry on the dais who bring together years of experience in the development and application of information technology in healthcare. And I feel privileged to moderate this discussion on a topical issue of extreme national importance and social relevance. I would, first of all, giving a background that I chair the Board of Governors of Amity University, responsible for developing institutes of medical education and research, and also taking care of Amity across the globe in Middle East and Africa. I would like the panelists to briefly introduce themselves, and then we can start our deliberations and invite the panelists to make a presentation on this topical issue. May I start with the lady on the right?
Thank you, sir, and Rajendra, for inviting me here. My name is Dr. Shubnam Singh, and I'm from Max Healthcare Institute, where I'm the Chief Executive of the Education Department, and I represent the Health Sector Skills Council, where I'm a governing board member, as well as the Life Sciences Sector Skills Council, and I'm a steering committee member of what has been recently launched by the Prime Minister on the 15th of July, what is called the PMKVY scheme, that is the Pradhan Mantri Kushal Vikas Yojana scheme. Thank you.
Yeah, good evening everyone once again. This is Krishan Girdhar from Presto Info Solutions. I'm the Managing Director of Presto, and is it audible? Okay. So Presto focuses on unified communication solutions, specifically focusing on the tele-education, which can be heavily used for skill upgradation, telemedicine and telejustice solutions.
I'm Dr. S.D.Gupta. I'm the President of Asia Pacific Association for Medical Informatics, also of Society for Administration of Telemedicine and Healthcare Informatics. we work at healthcare at the grassroots levels, and there the skills development is very, very important.
Good afternoon. This is Dr. S.D.Gupta. I am President IIHMR University. My basic background is public health. Passion is for research, more in policy and program management in healthcare. More moved into education, especially IT-based education, especially the MOOCs. I'm a medical graduate, did my MD, and then did my PhD in chronic diseases from the Johns Hopkins University.
Very well, thank you.
Thank you. I'm Terig Hughes. I'm the Managing Director for Elsevier Health for South Asia. Elsevier is a global leader in the development and dissemination of scientific, technical, medical information.
Very good evening to all of you. Myself, Dr. Sandeep Bhalla. I'm representing Public Health Foundation of India. I'm there as a Program Director Training and looking after the training component for the chronic conditions management, in which we are giving the training to the primary care physicians. And we have created a unique model in the country which we are going to present today. And once and all, thanks for the organizer and Mr. Girdhar Gupta for giving me an opportunity.
Good afternoon, everyone. I'm Rohit Kumar. I am the founder of a mobile platform for education that I am building as a new company called Chapter Apps. I am the former managing director of Elsevier South Asia, and I have been involved in the tech industry for most of my career and the last 6-7 years in publishing and education. And I stepped out to run my own company, and I would like to thank Rajendra for inviting me here today as well.
Cheers. Very welcome, and I'll take the privilege of inviting Dr. S.D. Gupta as the first speaker to this great event. Thank you.
Yes, sure. Thank you very much, sir, for giving me this opportunity. I see this topic on which I'm expected to share my ideas, a kind of a jigsaw puzzle. Medical education, training, and skill development, and then IT-enabled education, and then 21st century learning skills, and the challenges of 21st century in healthcare. So this puzzle is really difficult, but there are several pieces which could be really looked at, and then we try to solve this jigsaw puzzle by integrating this in a framework. I have no specific framework in my mind at this point of time, but I can share with you the pieces of this jigsaw puzzle. In our country, what is happening is that health itself is going through health transition. There's a health transition going on, the demographic transition going on, social transition is going on, economic transition is going on. I'll be more focused on health transition. And one of the most awesome outcome of this health transition is our changing character of disease burden. We're not far away from today, maybe next 5 years, maybe 2020, our disease burden patterns will change. We are already moving fast in that area. So 70% of the disease burden will be because of the chronic diseases. And they include diabetes, cardiovascular diseases, cerebrovascular diseases, accidents, injuries, chronic obstructive pulmonary diseases, which are not attended to by the people, and then so many endocrinal disorders, in addition to injuries and road accidents. So the scenario is changing fast, and we expect this transition to be complete in next 5 years. So there is a huge urgency of changing our minds and preparing our human resources to deal with this challenge. How do we do that? But on the other hand, we have a situation where we find the status of skills of our human resources that are engaged in delivery of care. Whether this is secondary level care or tertiary level care, I don't know much about tertiary care level. I'm sure they are very particular in hiring people based on their skills. But I'm concerned about the skills at primary health care or public health and the secondary level care. I feel so sorry about this. There's a huge skills deficit in our country. You know, you might be aware of this National Family Health Survey that regularly gives information about the situation as well as the training or skill levels of our people, our auxiliary nurse midwives, our ASHAs. They don't know how to measure blood pressure. Most of them. They don't know how to do hemoglobin estimation. I'm not talking about high-end technology. So the basic skills, so huge skill set deficit that we face. I'm also worried about our doctors who are providing health care in the peripheral areas as well as secondary level institutions. I don't know how many of can read reports of sonography, ultrasound. How many of them can really know about, do they know about the modern investigations? And moreover, do they know the technology which is being used and which will be used in future? So we are facing a lot of challenges in knowledge and skills of our healthcare providers, including physicians, nursing staff, technologists, technicians at all levels. So how do we deal with this? I think we need to work on building skills. A fortunate thing that is happening now in our country, our campaign for Digital India and our campaign for Skill India, these two missions that we have. So these are the other two pieces of the jigsaw puzzle, but this should be the solutions for our puzzles that I have just narrated about. So we have a huge network of human resources at all levels. How do we build their skills to face challenges of the new paradigm due to chronic diseases? And the third thing that is fast emerging is the healthcare technologies. Is our doctor today know the new technologies? Do they really know how to use those technologies? And they are the future providers of the future diseases that we are going to face. So we need to really work on building human resources on scale. And how do we do that? So this information technology techniques and technologies can be very handy for this. So we see that more than 50% of the population now is on the Facebook. Our doctors are on Facebook, our A&Ms are on Facebook, our technicians are on Facebook. Can we harness that resource in building their skills? How much this can help us? We have webinars, we have other YouTubes, can we really use them? I'm not aware of new technologies that will be coming up further. We just don't know what is there in the store. But the existing technologies, digital technologies that we have, can we really harness them? You might be aware of this new education tool, MOOCs, Massive Open Online Courses. It was a kind of a mystery to me when people talked to me about MOOCs, and in this country, we still don't recognize online courses. We don't recognize MOOCs here still. But this MOOCs could be a very, very strong media, digital media, to really build skills among our people. It was a mysterious thing, and I did not know how to do MOOCs, but I went through training in MOOCs then. So I was expert panelist for the WHO for developing MOOCs, and that is in very special area on implementation research in healthcare. So I happened to go to a technology institute in Switzerland, and we learned how to develop MOOCs. And I have started now believing in MOOCs that could really transform and fulfill our dreams of digital India, and using this digital technology in making Skill India. So I see a great future, but let us open our minds to adopt new technologies. Let our governments and the concerned departments should create policies that enable us to use such technologies and do certification for them. Don't stop us, rather facilitate us that we use modern technologies to realize the dreams of Skill India and digital. I shared yesterday that what the University Grant Commission says, or what All India Council of Technical Education says, they just don't allow you online education. No approvals. I think this all has to change if we want to really develop skills, build skills in the human resources that are engaged in healthcare delivery, right from physicians level down to the grassroots level worker. Thank you very much, sir.
Thank you very much for sharing the jigsaw puzzle without a solution yet. So may I invite Dr. Shubnam to make a presentation?
Thank you, Dr. Nagpal. I'll just walk into the discussion and give you a different perspective to this piece. So you have, I don't think there's any element in whether it is medicine or life today where there is not permeation by information technology. The usage of IT is now second skin to what we believe are most people. This is in part true, and on another part it is not true. When you look at the delivery model, when you look at quaternary care, tertiary care, secondary care, primary care, all of these are, quote unquote, required to be linked onto a platform, and that commonality is to be provided by information technology. So it has been an insidious permeation into the entire healthcare delivery system is what we are looking at. The question that has to be asked to ourselves who are in this piece, exactly what Dr. Gupta said, what is the level of our preparedness to be able to harness this to ensure that there is equity in healthcare delivery, there is true quality in healthcare delivery, there's true scalability in healthcare delivery, there is the ability to harness the information which is therein provided and thereby spawn this entire new sea of life which is called data analytics, predictive analytics, and so on and so forth. So when you look at all these lovely gizmo words, rise at the center is an individual who hitherto has not been exposed to this animal which is known as IT, and we have to ask ourselves, how are we preparing them and what is it that we are doing to skill them? So it is against this backdrop, given in our daily lives as we do in healthcare delivery, you're challenged. I can see a very senior colleague of mine here, Dinesh, sitting. He'll be able to tell you the challenges they face. And then you look at the people who are providing these inputs. So when you look at the people who are providing these inputs, and I'll give you an example of what we had in Max Healthcare when we first digitalized all our radiology pieces. The technicians who are absolutely marvelous and wonderful, doctors who are really great, were at sea when the first few MRs and CTs were sent on PACS. They had absolutely no idea of how do you make this happen. And on the other end of the spectrum is an ASHA worker and an immunization person who catches a bus from her central Mufassil town, goes down into a village, writes in a notebook, I have immunized so many children and after so many weeks I'm going to come back to it. How are we going to address this conundrum? And this is precisely why we formed what are called the Health Sector Skills Councils and the Life Sciences Sector Skills Councils. And that was to put together the framework that IT will be threaded right through against what are called now National Skills Qualification Frameworks. So what are these National Skills Qualification Frameworks? These are frameworks which will ensure whether you are a doctor, nurse, PhD, BA, MA, AICT approved, NSQ, whatever, wherever you get your degree, you will have some fundamental knowledge of IT. This is what is going to be the strength of this country. That till you do not embed it into the learning at the school level and then thread it along the level of all levels of allied health workers, nurses, doctors, we are not going to be able to realize our dream. When it comes to specific manpower, which is going to manage health informatics, or whatever terminology you would like to carve, you have carved out today willy-nilly minimum of 7 job roles which belong to this sector. And these job roles, if actually done properly, will realize a dream for this country, and I'll just walk you through them, which can be at either entry levels, mid or advanced or masters, in relationship to compliance and risk management, education, as Dr. Gupta said, communication, informatics, data analysis, IT, the basic infrastructure of how do you manage it, operations, medical records and administration, and most importantly for every PE who's interested in this sector, revenue cycle management, coding and billing for insurances. So this is such a vast array. We have to take care that anybody who gets trained in this is trained appropriately and thereby compensated as well as give career progressions to them. At this avail, we are working on it both at a ministerial level as well as through the Sector Skills Council, ensuring that it is done in a systemized and organized fashion. Thank you, Dr. Nagpal. I hope I wasn't all over the place.
Tremendous. I think very well. You used a very important word, which is not very often used, and that is healthcare informatics. It is different. It is application of information technology. And we need human resource in application much greater than in development of the programs. We have known about software writers, we've known about network engineers, but now we need desperately in the realm of healthcare, people who are trained in informatics. Thank you for bringing this out so well and so briefly. And now I'd like to invite Mr. Hughes for his presentation. Thank you.
So I'm the managing director for Elsevier Health in India, South Asia. What does Elsevier do? Well, we're a global leader in the development and dissemination of scientific knowledge and medical knowledge. So we combine content with technology and analytics, which helps to empower individuals and institutions to realize the potential of information, to improve academic, professional and clinical performance and expand human knowledge, and to generate positive and sometimes groundbreaking outcomes in critical domains of human endeavor. But it all starts with the people. So in Elsevier, we have 7,000 employees in over 150 offices worldwide, and together we're producing content that serves 30 million scientists, students, educators, and health information professionals. Some of our products and brands that you may recognize are The Lancet, Science Direct, our research platform, Clinical Key, Scopus, Nursing Skills, Clinical Learning, MyPGME, Gray's Anatomy, and NETAS. So today, while the world offers about 1.5 doctors on average for every 1,000 individuals, India is providing only 0.5 or 0.6 doctors for every 1,000 individuals. Due to the unfavorable doctor-patient ratio, the stress on the healthcare system is overwhelming. By 2031, it is possible to move from 0.5 or 0.6 per 1,000 to 1 per 1,000. That will require, obviously, an almost doubling or more than doubling, given the growth in the population, of the number of doctors. To fulfill this vision, there'll be a need to increase the annual intake of medical students from about 50,000 today to about 70,000. It's not all about doctors, however, and we also need trained nurses and allied healthcare professionals in adequate numbers and well trained. It's logical for the government to increase the number of colleges as well as to allow more students per college. That, of course, leads to some other challenges. Some of the challenges include the fact that about 50% of the existing medical workforce doesn't practice in the formal healthcare system. In terms of allopathic doctors, that figure's about 25% for a number of reasons, including insufficient incentives, lack of career growth, and migration to other regions. Other challenges include the rapid growth in private education institutions, which, while necessary on one hand, result in a shortage of well-trained faculty, or rather the shortage of well-trained faculty threatens to compromise the quality of the teaching within those institutions. We also have a lack of resources for students. They suffer from information overload, partly as a result of low adoption of newer learning and teaching methods. There's also a lack of adequately trained healthcare workers. So there's a lack of standardization of education and evaluation. And as a result, a high percentage of graduating doctors and nurses and paramedics lack adequate workplace skills. There's also a lack of focus on continuing education and professional development, CEPD. CEPD is neither mandated nor is it part of the professional culture. So it's a nice to have rather than a must have. Addressing the challenges, I think, requires collaboration between government, academia and private sectors to standardize and improve the quality of education, both at the undergraduate level as well as the practitioner level. I think we also need to focus more on skill development and employability and use newer evaluation methodologies. We also need to rely on e-learning as a tool for self-paced and adaptive learning and simulation-based medical education for more interactive classroom teaching and greater retention by students. And also provide access to credible data banks for equipping students and practitioners alike with answers to complex problems. So how can ICT help address these challenges? If we look at some of the trends, we see increasing use of blended learning, growing focus on measuring of learning, which is very important, and advancing cultures of change and innovation and increasing cross-institution collaboration. How is Elsevier in particular helping? Well, in India, Elsevier has developed an e-learning and simulation tool to enhance the classroom experience. It's called Clinical Learning. Clinical learning helps address the issue of issues related to recall of difficult concepts and also the level of engagement in the classroom. So in a study that we performed in 2014, we showed that the use of clinical learning was able to increase classroom interactivity and improve overall recall value. We also have a product called Clinical Key. It's a web-based clinical search engine with smart content which delivers relevant answers to doctors and students. And in another study that we did last year, we found that the use of Clinical Key was able to improve the quality of clinical practice by actively engaging clinicians. This led to a significant increase in the usage of online medical databases and significant time savings and improvements in clinical outcomes. We also have a tool called Mosby's Nursing Skills. That's an online solution for providing best in skills and procedures reference, as well as learning and competency management. It has nearly 1,000 nursing skills, which includes tests, checklists, illustrations, video animation, and demonstrations. It also has interactive functionality with the ability to customize skills for institution-specific protocols, and it's endorsed by the American Association of Critical Care Nurses. So, what's next? In terms of students and faculty, we would recommend implementation of exit exams with minimum national qualifying criteria, and standardization of teacher recruitment and onboarding and training programs. For academic institutions and governing bodies, we'd recommend accreditation of teaching institutions and a focus on CEPD for all healthcare professionals. We'd also recommend the use of IT to enable blended learning and adaptive learning and testing and simulation-based medical education. To sum it up, I think we have a lot of the tools available, or maybe to put it another way, we have a lot of pieces of the jigsaw puzzle. I think we need to come together to build the picture and the vision. Thank you.
Thank you very much. Great. Thank you, Mr. Hughes, for sharing a gamut of applications, particularly in the field of healthcare, which include distant learning and also simulation in clinical teaching. This is a very big challenge to bring the students to the classroom to meet the needs of this country for such a colossal deficiency in human resource. And I think your technology and your techniques will be a significant benefit to our country if applied earlier the better. Thank you very much. Now I have another stalwart, Mr. Krishan Girdhar, MD Presto, to make his presentation.
Yeah, so I'd like to give you two contrasting scenarios. We go to Silicon Valley in US. We find that in most of the top IT companies, we have almost 15 to 20% of the core R&D engineers who are from India. So they are doing wonders there. Any Silicon Valley company who thinks of opening up an office outside US, they think of Silicon Valley of India, which is Bangalore. And that becomes the second worldwide headquarters for them. Another statistics which was published by NSDC, National Skill Development Council, last month, that in India, the per person GDP earning is 10% of what a person earns in US. It is much less than any of the BRIC countries. Brazil, it is 70% above us. China is 80% above us. Russia is also 50% above us. So one thing is that Indians have huge talent, huge aptitude, so there is no issues in terms of the talent available with the Indians. But in India, we are not providing the right kind of skill upgradation to those particular professions. Now that is something which needs to be bridged. And as Dr. Gupta mentioned, that it's a jigsaw puzzle. And we need to figure out a solution for that. Last month, 1st of July, our Prime Minister inaugurated Digital India Week. On 15th of July, he inaugurated Skills India. If we are somehow able to connect these two particular things, I think we have a solution. Now what Digital India talks about, it talks about investing 1.2 lakh crores into skilling up the entire IT infrastructure. The first phase itself, which is the National Optical Fiber Network, talks about reaching up to 2.5 lakh gram panchayats. 2.5 lakh gram panchayats having a fiber, and that too they are talking of 96 cores, 2 cores are good enough to take 1 gigabit of traffic. So the kind of the capacity which gets created is going to be humongous. Now once the fiber reaches at the Gram Panchayat, what are we going to do about that particular bandwidth? That bandwidth has only 3 applications as per my understanding. One is education, second is health, and third is entertainment. I can't think of any fourth application apart from the regular e-governance applications which doesn't need too much of bandwidth. So we have a solution that now we have a bandwidth which is available. Now what next? We need to create the content. In content, come back to the skill development thing. National Skill Development Corporation has empaneled 200 partners to give the skills training across domains, out of which I told there are 14 to 15 partners who are working on the health trainings itself. Now training is required at each and every nook and corner, that's a fact, at whatever levels we have to train. Today as the MD of the company, I have to recruit a sales guy, I don't get a sales guy. I want to recruit a technical guy, there is no skilled technical guy available. I want to recruit a finance guy is not available. And that too we are talking of a city like Delhi. You think of locations where you go to the remote places, there is absolutely huge requirement of the skill upgradation which has to happen. I'll give you 2 more examples. One is that I went to Mussoorie last year, so I was on the Mall Road. There I saw one board of one of the premier institutes. I'm not publicizing any name, but that was for Akash. For IIT and medical training, come to Dehradun Center. Now a student who is willing to pay 2 lakh rupees for 2-year course, he has to move from Mussoorie to Dehradun, which is 1.5 hour distance, so as to, even after paying that particular thing, 3 hours of up and down every day during his 11th and 12th days. 11th and 12th, which is the most peak hour in terms of the school pressure, the entrance pressure, he has to spend 3 to 4 hours just traveling to Mussoorie and Dehradun. And Mussoorie is one of the major towns I can talk about. Now we do next level of analysis, Akash and Narayana. They have got 60 to 70 centers across India, but across only 25 to 26 cities. 25 to 26 cities means we have not even covered all the states. Leave the tier 2 and tier 3 or tier 4 cities. We have more than 123 cities in the country which have a population of more than 4 lakhs. This is as per the census of 2011, which should have reached up to 4.5 lakhs or something like that right now. Now till the time we reach those particular locations, we can't take our country to the next level. So that is something we need to enable. So in case we are able to, I would say, connect these 200 training partners of Skill India and maybe many more which are coming up to this backbone which is getting created so that the content and the training gets developed. Now coming on to the e-health initiative, there are a lot of ways in terms of delivering the education over the IT infrastructure. One is that creating the CVTs, putting on the website, and we have a lot of, I would say, website companies which are coming with content. But what I have personally seen as my experience in last 20 years in the industry, Indian student is more used to a instructor-led training. Indian companies prepare a lot of CVT stuff. They are great success in US and the developed world. In India, no one wants to go through that. Our mindset of Indians is till the time we see the instructor, we work in a group, they don't go through that particular thing. There are a lot of, I would say at the school level, we see a lot of websites like Khan Academy, Merit Nation. You subscribe to your kids for that. They'll start working for 1 month, 1.5 months. After that, they don't even open those particular sites. It is not that the content is not there. It's the mindset of the people. So we need to have some interactivity which has to be built up so that the student is able to feel that they are still working in a group. At the same time, they are able to use this particular infrastructure. Tele-education could be one of the places where setting up one sort of a tele-education center in these 250,000 locations, and this is just the first phase. Next phase, putting together, it will become 6 lakh locations. So that is something which we need to work upon, and I am sure that various ministries and government is going to connect these two particular things. Thank you.
Thank you very much for sharing a very, very critical issue of multi-tenant IT backbone for the country. And also use a very important word called scalable. Whatever we do should be scalable. I think it's a fundamental need today. Which
Sir, in the old days, we used to hear a radio ad, I don't know how many will recall, कि हीरे तो हैं पर धूल में पड़े हैं. हमारे इंडियन टैलेंट का यही हाल है. We just need to polish them, and there are diamonds in billion. We are a billion population, and everyone can do wonders.
Thank you. Now I'd like to invite our Dr. Sandeep Bhalla for his presentation. Thank you.
Respected Chairperson, panelists, delegates representing the various parts of the country, I'm going to give you the overview about what PHFI has created to scale up the activities in the field of capacity building for the primary care physicians in such a way that it has become a role model now in the country, and the globally people are looking into this. This is what India needs to do that, and this is what the things are available, and we are looking into various partnerships now, how we can join together and take it to the other countries also. As you all know, I'm representing Public Health Foundation of India, and this is an organization which has been set up by 14 former Prime Minister of India to build the capacity in the field of public health. It's a purely public-private partnership model. We are working very closely with the government, academia, civil societies, and industry leaders. Why I'm saying all these things? Because chairman of PHFI is none other than but Mr. Narayan Murthy. We have people like Dr. Amartya Sen, Dr. Raghunath, Dr. Peter Pyatt. They are the people who are representing the strong board of PHFI, and we are having, our president is none other than but Dr. K. Srinath Reddy. We are strongly into education, training, research, affordable health technologies, communication, advocacies, and policy development. Under the umbrella of PHFI, we are having Indian Institutes of Public Health, Delhi, Hyderabad, Bhubaneswar, Gandhinagar, and fifth one is in Shillong. How PHFI has created a model in the field of chronic conditions, because as you all know, chronic condition burden is more than 70% in the Indian disease itself. And PHFI is playing a little drop in an ocean to create a capacity in the field of chronic conditions management by upgrading the skills of primary care physicians. It is very hard to say that we are as an emerging capital of diabetes. We should not become the emerging capital of diabetes, but we should become a diabetes care capital of the world. We have huge manpower available with us. Only the thing is there is a need to tweak them, there is a need to give them the skills, and so that they can able to manage such type of disease managements into their own areas. You don't have to come to the metros. At your own village, you can do that. We started a first initiative to bring the capacity of physicians known as certificate course in evidence-based diabetes management, which is a purely a public-private partnership model where the PHFI has joined hands with a strong academic partner based at Chennai, Dr. Mohan Diabetes Academy, and we got the education grant from Amity. And this model has become the flagship course in the country now, and this is the only model in the globe which got the IDF recognition. International Diabetes Federation has come over to India. There is no need to go out from India. I'm always saying, come here. As sir has already said, that diamonds to hain, but dhool mein hai. Sir, usko dhoond lo to sab kaam ho sakta hai. So India mein diamonds are available. We just have to make them come out and to do the things in the right way. We started another course known as gestational diabetes. Then we started a course known as advanced course in prevention and management of diabetes and cardiovascular diseases. Then we started a course on thyroid disorders. Now there is a course which we are going to start on diabetic retinopathy. These all courses are to upbring the capacity of primary care physicians. Our focus is on primary care physicians itself. Why I'm saying this? If you see the specialist level endocrinologists, hardly 40 endocrinologists per year, they are coming out from the various medical colleges per year. So majority of 70% of the population are still going to the primary care physicians. Until unless you don't build up their skills, you're not going to get the right way of the treatment from them. It's a course which is a 12-modular course, once in a month, at your own place on a weekend. You don't have to go through all the 12 days. Once in a month, any doctor can afford 5 to 6 hours. This is the trick which we have played, and it worked out very well. Once in a month, 5 to 6 hours, anybody can go. As my previous panelist has said, there is a need to have interaction, because still India believes something should be there in books, something should be in handy, and something should be interactive. That's what this model is playing a big role. We have selected the top-notch endocrinologists and cardiologists of the country. They are acting as a faculty, and they are imparting the teaching on the standardized course modules prepared by none other than but the panel of the 15 national experts, those who are top-notch. all across country, along with Dr. Mohan Diabetes Academy. Just see the scale. In the first year, we have trained 1,208 doctors. In the second year, 1,568. In the third year, 2,306. And this is the fourth cycle of this course is going on, and we have trained more than 2,350 doctors. In case, if you total all this, more than 7,500 doctors have already been trained into this evidence-based diabetes management course. This is the panel of national experts, who's so who in the field of endocrinology. Dr. Amrish Mittal, Dr. Nikhil Tandon from All India Institute, Dr. Wangnu, Dr. Anil Bhansali, Dr. Sarita Bajaj, Dr. Shashank Joshi, Dr. R.V. Jaikumar, Dr. Vijay Vishwanathan, Dr. A.K. Das, Dr. Bipin Sethi. They are the people, those who are putting their efforts in finalizing the course curriculum after getting from the Dr. Mohan Diabetes Academy. Other than that, they are also updating the curriculum based upon the feedbacks which we are getting regularly from various participants when we are sending our observers to the different centers. If you see the scale, the average experience of these physicians, more than 13 years clinical experience. If you see the doctors are not coming only from the private sector, people are coming from the government sector also. People are coming from the BHEL, various PHUs, CGHS, ESI. So people are joining and people are getting their evidence-based diabetes management guidelines, as well as the portfolio how to manage the diabetes management into their own clinics. This is the scale. Just see from Jammu to Kerala, we have centers all across country. You don't have to come. There are places like Kakinada, Kumbakonam, Nagarkoil. People are getting the training from those places only. If you see Jaipur itself, we are having 4 centers. In NCR region itself, we are having around 10 centers. So this is the scale of the program with 162 faculty all across country, 130 centers, and this is the way which we are imparting the teaching. This was the day when the IDF President Sir Michael Hurst came over to Delhi, and he has declared that this is the first course in the globe which got the IDF recognition. So this is what India is doing. This is what we people are jointly doing all these things. This is the certification which IDF has given to Public Health Foundation of India for excellence in providing the education in the diabetes management, and this is there for recognition is there for 3 years. Last year, BMJ has started the first time in India BMJ Awards, and we applied for excellence in medical education category, and we got as a finalist BMJ Award in India itself. We do the evaluation because we believe unless you don't evaluate yourself, you can't improvise yourself. So we do the evaluation of each and every cycle at the end of the courses. We are sending the observers on site to the different centers. They are giving us the feedback, and when we do the evaluation every year, we are getting a lot of feedbacks and we are improvising on that. Based upon this same model, we started a gestational diabetes course. Each center, 2 faculty, gynecologist and diabetologist, and they are imparting the teaching. Here the corporates have joined hands with us, and this is a joint model again. Here Johnson & Johnson is acting as an education grant partner for us, and we have trained more than 2,700 doctors in 3 years in the management of gestational diabetes itself. This is the accreditation which PHFI has received from South Asian Federation of Endocrine Society. They have accredited this model. Now this model we can implement in Nepal, Pakistan, Bangladesh and Bhutan. You can scale up and you can go there also. This is another course. People thought diabetes along with cardiac is needed, so we started another course, and this is advanced course in diabetes and cardiovascular disease management, and Abbott is acting as an education grant partner with us, and we got the technical partner as the World Heart Federation, and 7,756 doctors have done that training. This is thyroid, another initiative which is a thyroid course which we have started. So in all, if you see, we have created a benchmark in the country in the field of capacity building for primary care physicians, and we have done that. We have started the GIS mapping of our participants as well as our centers also. We have a strong monitoring mechanism by which we are doing the quality measures, and a lot of state governments have come up and they have adopted this model. This is the peculiarity, public-private partnership, which we always talk about, PPP. Kerala government, MP government, Gujarat government, they are the governments, those who have taken up this model for the training of their physicians. They are based at PHCs and CHCs. So this is all from our side which PHFI is doing. A lot of media coverages had happened. This is the network which PHFI has created, covering 150 cities all across country. This is a very huge model. These are our various international partners for this: International Red Cross Society, World Heart Federation, IDF, academic partner Dr. Mohan, Arvindai, Center for Chronic Disease Control, International Society of Hypertension, British Hypertension Society, various state governments as educational partner. This is in summarizing all these things. I can only say since last 5 years, more than 12,000 doctors trainings have been done in the evidence-based chronic conditions disease management. I would like to thank our President, Dr. K. Srinath Reddy, our Vice President, Dr. Prabhakaran, all stakeholders and team of 35 colleagues, those who are working round the clock for running such type of initiatives. And last words of our people's president, I want to say that excellence is not by accident, but it is a continuous process, and PHFI is working on that excellence to create a benchmark in the management of chronic disease management. Thank you.
Thank you. Thank you, Dr. Bhalla, for sharing this scare of lifestyle diseases with a focus on diabetes and what PHFI is doing to control the scourge through training of human resource, both at the professional as well as the frontline level. Now I'd like to invite Dr. Gogia for his presentation.
Thank you, Dr. Nagpal. First of all, I have to thank Mr. S.D.Gupta for inviting me as in addition to what I was supposed to talk. This is based on what I told him in the morning of what I am presenting, and he said that this is important for this session also. So I would just like to know who all of you have attended the morning's talk. Most of you have, so then I don't need to go through it. You would have noticed in that we did talk a lot about requirement of skills in the very, very rural areas, and I'll just briefly go through that again for the people who could not attend. I don't want to go through the presentation. Basically, the largest gap in skills is in the rural areas. And if we want this country to continue growing, which China did long back, it was to reach out to the rural areas. Our urban areas are well developed, our rural areas are not. And we don't have jobs in the rural areas. Doctors who are trained out there don't want to go there. And not only because of this, there is also a gap in other facilities. Healthcare is not available because the trained doctors are not there. And okay, we brought out a solution of telemedicine. But I say, and it's just a conjectural feeling which is not, I can't quote from anywhere, I say telemedicine gives you half a doctor. It is very useful where there's no doctor. It is useless if there's a full doctor. So, I mean, if you look at a person who is staying in Delhi, you ask him to do telemedicine, he said, why, I can go to Max, I can get my treatment. But if he has to travel 3,000 miles or even 20 miles, and I've seen this happen, this is what actually inducted me into telemedicine, was I was in Mussoorie, and he was talking about Mussoorie at that time. I have a cottage out there, just by chance. And on taking a walk, I saw people carrying a person on a cot just to reach the road. And I said, if I can stop this even once, I've done something. And what is the reason? I say, I took the simple example of the dressing in my slide. A dressing costs you 20 rupees. But when he has to go to the town for that, it has already gone up to 2,000 rupees because the cost of transportation, a person has to come along with you. Now, if we can give the right dressing equipment, we can give the right drugs for doing the dressing, and more importantly, the knowledge of how to use those equipment and the drugs. And this is where the gap which telemedicine and IT can easily cover. So, again, let us not, I am a doctor, although I am a doctor, and a lot of people say that we should not, RMPs and quacks are to be degraded, and I don't think so. They are the people everybody will turn to at the time of need, because they are the what are called Andho mein Kana Raja, they are the Kanas. And we just develop the skills a little more, make them more than a Kana, and we have done wonders. So that is one thing which IT can easily do, because IT is basically knowledge and information management. Just transmit the knowledge across, make it possible. We have to create a support system so that then the knowledge, information through IT takes place on a continuous basis. You show him a patient and he says, no, you have not done this wrong. Next time you'll do it better. So that has become the continuous process of learning, and it can be part of a skills development program. Our own projects, which Sathi is doing, the 3 projects that I showed you in the morning, all of them depended on trained workers in the rural areas who were trained further how to not only manage a problem to whatever they can, like for eye problem. They used to do the examination, they used to send the photographs across. After that, the stitch removal, glasses, everything was done locally. So instead of 5 trips, only 1 trip was required to the hospital for the surgery itself. So, but the training for making glasses we imparted to them, training of communicating through the IT and sending the photographs was imparted to them, and that 1 month training program took place for these people in Delhi. We brought them here, and now they've been working in Mizoram and giving remarkable results for the people out there. That is one part I want to talk to you. That is, there are other 2 important components of skills that I want to talk to you, which is over and above that talk. One is that one of the main chicken and egg situation which we have in healthcare IT in India is that there are not enough people trained in healthcare information technology. Me, I am supposed to be an HIT expert, but I have not had any formal training. And of course, IIHMR, thanks to them, has started a course, and some of the students are sitting there, and but it's too few. We do need to develop HIT training across the country so that they can be the CIO officers and do this entire program that we're looking at, because they have to look at the networking, they have to look at the healthcare aspects to it. That is another aspect we have to look at. And regarding that, there is also no certification process for them. AICT is providing some of the training, but just for management. It's not for pure HIT. HIT training, fortunately, the biggest organization which does this training is called IIHMR, American Healthcare Informatics Management Association. And IIHMR is creating an India chapter. We are launching in October, and we are looking for partners who will do, they provide online courses, something like the MOOCs that he said. But they will require a physical component. They will also require the overseeing the examinations and all that. And any university which is interested, and we are already talking to IIHMR, is interested to participate the physical component, as Mr. Krishan Girdhar very rightly said, is important for the Indian these things. We are willing to give them those things, and they can take over this. That is one information which I definitely wanted to give you. And these people are of all 6 levels of possible training, right from the basic data entry operator to up to CIO of a hospital. They are giving that sort of training. And the third thing that I wanted to talk to you in this session was using IT for skills development itself. And I'm now talking about a certain concept, and of course it's been mentioned a little bit, that we have to give them additional training, just like, how to take a BP and all that. You must remember that most training in medical careers has been through books so far. But certain important things, procedures, can only be taught through videos. There are, webinars available. In fact, I myself, I'm a plastic surgeon. We have done complete transmission of surgical sessions, and we have had global people participating in that. And the library has been created by the surgeon class. A lot of people have created these libraries, but getting them utilized, get them formalized. There's an organization called MedTech, which is providing video-based trainings and for the trained people itself on specific procedures, how to do a cleft lip. Or even for these, people who are working in the rural areas, for the nurses, how to take a BP, putting the thing. So that component also we need to look into, and definitely with the help of these, it will be a comprehensive development of healthcare, and besides, it will help jobs reach everybody to this thing. And of course, the diamond will come out. Thank you.
Thank you very much. Thank you, Dr. Gogia, for such a elaborate description of your efforts in skill development. And now we have the last speaker, and that's Mr. Rohit Kumar.
So, good afternoon, everyone. Thank you, Mr. Chairperson, sir, colleagues on the dais, friends in the audience, and colleagues I've worked with before. About 5.5 years ago, I had the opportunity to meet Dr. Deka, who was the then director at All India Institute of Medical Sciences. And he asked me that time, he said, do you have something to solve for the rural market, for education or training in the rural market? And 5.5 years later, we're still sitting here, we're still debating, how do we solve this problem? Because the problem is huge, it's not an easy problem to solve. And that time there were very few smartphones. The iPhone had just sort of come out, 3GS had just come out. Very few people in India had smartphones. And now when you think about what is actually happening, and I'll share with you a few thought processes on why I actually left my job to do this. So I started in January a company called Chapter Apps Incorporated, which is an angel-funded company domiciled in the US with the goal to actually make in India. And the co-founder is actually a Silicon Valley accelerator called Studio 9+, which is part of UWeb. And they're actually helping me build the product and build the software. Our mission is to help people learn better and become more effective by providing bite-sized content written for consumption on the mobile. So one big challenge today we have is that even if you put the same books available to read, other than an iPad, they're not that easy to read on a small screen for the mobile. And the second is to make this content affordable so the users only buy what they need. One of the discussion points that I was listening to and we all were listening to is obviously about IT training. What I'm trying to do is actually take away the need for that IT training so that every user can use what they need on their phone. There's no IT infrastructure involved. The only network is the 3G or the 4G network as it rolls out. So look at the global smartphone subscription growth. It's about 2.1 billion smartphones in the world, grew 23% in last year. In India, that number of growth was 55%. So more than double the global average of growth in smartphones. And where are these phones growing? They're actually growing all over. My daughter came to me a year ago and said, I want a smartphone with a front camera. I said, why do you need a front camera? He said, so I can do Skype with my mother in the village. She wants to see me. So it is penetrating every strata of society. There are 16 countries where the smartphone penetration is less than 50%. India is one of them. The worldwide global average is 30%. Only 5 countries with a population of more than 50 million, which is US, Japan, Germany, UK and France, have greater than 50% smartphone penetration. The source is the Mary Meeker Internet Trends, and she actually writes about what is happening. Interestingly, she actually has talked about India. She has talked about bite-sized content for the mobile, and she's talked about education as 3 key areas that will see explosive growth over the next few years. Global internet usage, overall traffic was up 20%. A large part of the traffic that was up was actually on videos. Mobile data traffic has been actually growing at more than 60–70% a year for the last several years. And mobile videos becomes a very key part of it. And mobile videos, the demand was so high to get it working in a disconnected mode. So that means the minute you're out of an office or out of an environment with internet, you want it to work offline. YouTube last year started YouTube offline videos. Right? So you can choose the video, press the button, it downloads on your phone, you can watch it later. So the trends worldwide, smartphone penetration is increasing rapidly. Students and employees want to learn on mobile in bite-sized modules, but where is the content? Who's going to write this content? How is it going to come? Stepping back on content consumption, and this applies especially to the target population that we are talking about, the rural population. They're not that well educated. Their attention spans are also small. Their ability to understand is also limited. So the content has to be made so simple that it almost has to be done from scratch. So attention spans are reducing, ability to read big thick books is reducing, and yet most of the content we need today is either in the form of a book or available only on my laptop. So what is the opportunity? The opportunity is for a mobile-first platform to publish content, which is both user-generated, which means if
a professor decides to get a video taken of a procedure in their own campus and they want to put it up, today the option is to put it on YouTube. But if you actually want to get some more editing, add a few slides to it, and then upload it, there should be something to do that. And then there should be a marketplace for this content. So if it's really good, you should be able to sell it. So what is my company offering? It's actually building a mobile-first publishing platform to publish your custom content that could be shared only for private consumption. So whatever you might want to do within a small group, it could be anyone could create a private group, just like on WhatsApp, except that at the moment, I'm not automating that part. I'm actually providing that as a service to do that. This will include assessments and quizzes. And the second part is authored content from professors and experts as in the print world, and that could be available for purchase by the module and chapter. And the goal being that a lot of new content will come, and in addition, a lot of existing content would also be licensed from different publishers. This takes away the need for any IT training. Don't solve that problem. Solve the problem that people need to get trained. I will not be the only one doing this platform if this problem is to be solved this way. There'll be others as well. But in every business, solve the problem that you need for it. There'll be other people who will come up with a platform for it. So I was delighted to actually hear that you were looking at solving the IT problem because you really want to solve the problem of training. And my platform is going to be available for pilot testing from next month at no cost. So if anyone would like to try it with a small group of people, starting with just PDFs and quizzes to begin with, then adding videos as time goes on, I'll be happy to have a discussion and see how we can help you solve that problem. Because I believe in solving this problem. I think this is the problem to solve. That technically, if you can take away the pain involved in the IT networks. Let the Ciscos of the world focus on helping India get a better cloud system, getting India a better 3G system. The cloud itself should take care of your internal IT, right? Your Wi-Fi network should be good enough for people to do it. That's all you should worry about. So the consumer launch of this app on Android will be in October, and currently planned for iOS is November, but I may slip that based on the demand that comes out of the first few pilots. So thank you.
Thank you.
Thank you very much. I think it's been a pleasure listening to the distinguished speakers here. Now, we have a few minutes. Our chief guest is already here. We have a few minutes for an interactive session. Please have a few important questions asked. Name the distinguished speaker to whom you are addressing that question. Firstly, name yourself, name the speaker, and then raise the question. Please. Yes, the lady.
Hello. I'm Rupal Mehta from Everest Medical, and my question is to the last speaker. Sorry, I don't remember his name. Yeah. You just talked about great interesting things about the trainings online and offline and on a very small mobile devices. I had a suggestion. Why would you want to make your content so small and so individualized training? Why? Have you thought about deploying LCDs even in the remote areas? Now they would be connected to the internet and have a group training sessions where people can actually have a group training discussions, because one-on-one training would lead to also sometimes misinterpretation of the content being provided, or no ability to discuss with anybody, questions being unanswered. So how do you address some of those issues?
Right. So what I'm providing is a platform. The content by itself could be, let's say, PHFI or Max or anybody. The content would be geared for what the goal of the training is. The platform would be there to make sure that it can be seen either on a mobile or on an iPad or on a TV screen, right? So that it works for you. The second thing is there are obviously, if it's an online course like MOOCs, there are forums to discuss. Similarly, I have forums in my product as well, where you could ask questions and correspond with different people. So those are features that will be there, but my goal is not to make it only for individual one-on-one. How it is used is actually how it will evolve. So the basic first part of the platform is there, that's version 1. Based on where the demand is coming for how everyone wants to use it, we will keep adding more features based on that.
Thanks for the clarification.
We have time for 2 more questions. If there is anybody, please raise your hands. There are 2 good reasons if there are no questions. One is that we have been able to express what we want and everybody's understood. That's, I think, let's skip the second reason. What do you think?
Although we note that.
I am delighted to have chaired this session and for the distinguished audience. And now we have a VIP sitting with us. I think it's time for us to say thank you and enjoy yourself. Thank you very much.
Thank you. Thank you.